Good morning, everyone. I am Dr. Sushruth, MBBS MS General Surgery, and today we'll talk about the surgical management of carcinoma gallbladder. So, CA gallbladder is the most common biliary malignancy with a global incidence of about 2.3 per lakh population, with India showing a very high incidence per area, especially in the women of North and Northeast India. Complete surgical removal is the only potential cure for resectable non-metastatic disease. So, coming to the etiology of CA gallbladder, the most consistent etiology is cholelithiasis and chronic inflammation, with 75 to 90% of all cases occurring in the setting of cholelithiasis. Most patients with cholelithiasis will never develop malignancy, and there is no definitive cause and effect relationship, but likely due to chronic inflammation malignancy is present in these patients. Other risk factors include anomalous pancreaticobiliary junctions, bilioenteric fistulas, typhoid infections and carriers of typhoid, and porcelain gallbladder, especially the stipple type. The lymphatic drainage of the gallbladder helps us predict the lymphatic spread of the malignancy, with usually the regional lymph nodes following the course as shown, with cystic nodes being the first draining lymph nodes, followed by pericholedochal nodes draining into the posterior superior pancreaticoduodenal nodes, and finally draining into distant nodes like the interaortocaval nodes. Some lymphatics drain directly into the aortocaval lymph nodes from the pericholedochal nodes, and this explains the advanced nature of the disease at diagnosis. So the malignancy spreads via lymphatics hematogenously or along the biopsy or surgical wound tracts. The gallbladder cancer may show early metastasis, likely due to thin wall with narrow lamina propria, single muscular coat, and no serosal covering over the liver. So there is a high likelihood of regional invasion at diagnosis, with about 60% of the patients showing liver invasion, which may be regarded as T3 disease at diagnosis. A carcinoma gallbladder may present in the following ways. In the histopathological report after routine cholecystectomy, they may be discovered intraoperatively. Carcinoma gallbladder may be suspected before the surgery. In the early stages, it is likely to be asymptomatic or may present with right upper quadrant pain and anorexia. It may be present as an advanced disease in the patient with a palpable mass, jaundice, and weight loss. It may be discovered incidentally in about 50% of the cases, and about 40% of the cases may present as a disseminated disease, and in the remaining 10-15% of the cases, locally advanced disease is seen. So it is important to inspect the gallbladder at the time of the completion of cholecystectomy, and the gallbladder should be removed intact without any perforations, and a frozen section for analysis should be sent in cases of suspected thickening. This is the T staging of malignancy, with TIS being carcinoma in situ, T1 having T1A and T1B, which is lamina propria and muscle layer invasion, respectively. T2 has T2A and T2B, which is tumor invasion into the perimuscular connective tissue on the peritoneal side and tumor invasion to the perimuscular tissue on the hepatic side, respectively, with no extension into the liver. If there is extension into the liver, it is T3 disease. Uh, tumor in T3 disease also perforates the serosa, and T4 disease includes invasion of the vascular structures or invasion of two or more extrahepatic structures. This is the end staging, wherein N1 is 1 to 3 lymph nodes and N2 is 4 or more lymph nodes, and M1 suggests a distant metastasis in the disease. So, for incidentally detected gallbladder cancers after cholecystectomy, about 0.2 to 2% of all cholecystectomies may present with gallbladder cancer, and the treatment depends upon the depth of penetration and surgical margins. In T1A disease, where a likelihood of nodal disease is less than 3%, cholecystectomy suffices, with cure rates reaching up to 100% of the patients. In case of cystic duct invasion, A cystic duct margin should be sent, where if it is positive, a CBD resection might be necessary for the patient. For a T1B or a greater disease, an extended cholecystectomy is needed, wherein a R0 resection of the disease should be done. The draining lymph node basin should be dissected, and 2 centimeters of the normal hepatic parenchyma should also be removed. The regional lymph nodes include hepatoduodenal, gastrohepatic, and retroduodenal lymph nodes. So, for all the stages, the recommendations are as follows. For T1A, a simple cholecystectomy will suffice. T1B disease, liver resection and lymph node dissection should also be performed. So, a radical cholecystectomy should be performed. For the liver resection part, a standard resection involves anatomical resection of segment 4B and 5, but a wedge resection may also be possible, wherein about 2 centimeters thick wedge is resected. If negative margins are achieved, it's good enough and shows survival similar to a standard anatomical resection. So, wedge resection is equivalent in terms of oncology. If negative margins are not achieved with the standard resection, an extended resection may need to be done. Isolated invasions of local organs in absence of a distant metastasis also requires a local resection of the organ. So, our current practice is to perform only the extent of hepatic resection necessary to achieve tumor clearance. The lymph node dissection includes mobilization of the duodenum to assess the retropancreatic and aortocaval lymph nodes as the first maneuver of the surgery. The interaortocaval lymph nodes are sampled and sent for examination, and if they're positive, the procedure is to be terminated, as the disease is said to be an advanced disease in that case and may not lead to a curative resection. Once it has been confirmed that the interaortocaval lymph nodes are negative, lymph node dissection is continued and the local regional lymph nodes are removed. That is the gastrohepatic, the porta hepatis, and the retroduodenal nodes are removed. That is station 8, station 12, and station 13. So, another event is port site recurrence, which has been shown to occur in 8 to 30% of the patients, occurring in 4 to 10 months of time, and shows poor prognosis in a lot of these patients. The direct contamination of the ports, aerosolization due to pneumoperitoneum, immune responses, carbon dioxide, and surgical techniques are factors that may contribute to port site recurrence. The incidence of recurrence of carcinoma at the port site is similar whether the patient presents with a primary tumor of T1, T2 stage or a locally advanced tumor of T3, T4. Patients with intraoperative perforation, though, have a higher incidence of recurrence. The port site recurrence is a marker of overall aggressive disease. It is rare for port site recurrences to occur as the sole site of these disease. Thus, port site excision is therefore not a routine practice, as these do not lead to an increase in the overall survival of these patients. The resectability and the non-metastatic nature of these tumors should be assessed, and if confirmed, an attempt to resect these tumors should be made. A diagnostic laparoscopy should first be done to exclude peritoneal metastasis. Direct extension of the tumor into adjacent structures like the hepatic flexure is not a contraindication to resection as long as negative margins could be obtained after resection. It is important to stage the disease at operation. If distal nodal mets are found, the resection is to be avoided. There is no role of debulking without complete resection. For assessment, imaging should be performed with the USG, abdomen being the first examination, with the most common finding being a large mass replacing the gallbladder. Other findings include an irregular mass, focally placed, thickening in the gallbladder. For cross-sectional imaging, CT or MRI can be done to assess the local extent as well as distant metastasis. MRI is better for CBD invasion status, and a PET can be used as a valuable adjunct in searching for metastatic disease when CT and MRI do not give adequate information. If a gallbladder malignancy is suspected on clinical or radiological grounds, histological diagnosis is unnecessary. Gallbladder cancer has tendency to seed peritoneum, biopsy tracts and surgical wounds. Thus, biopsy increases the risk and is mostly avoided in these cases. For advanced diseases, the goal is palliation, with palliation of the symptoms like jaundice, pain, and gastric outlet obstruction. For jaundice, stenting of the biliary tract should be done. For pain, if medical management is not enough, The patients can undergo a celiac ganglion block. For gastric outlet obstruction, endoscopic stenting or gastrojejunostomy can be done, endoscopic or surgical. So, in summary, carcinoma gallbladder is the most common biliary malignancy, and the risk factors include chronic inflammation of the gallbladder, most common risk factor being the cholelithiasis. Early lymphatic spread is seen, and it may be advanced at presentation. Almost half of them are diagnosed incidentally post cholecystectomy for gallstone disease. Complete surgical removal is the only cure in surgically resectable diseases. For T stage 1A, simple cholecystectomy may suffice. For anything higher, extended cholecystectomy with resection of segment 4D and 5 with en bloc regional lymph node dissection is to be done, and bile duct resection is done if the bile duct margins are positive. Thank you.